working on a couple of things here to fill this slot, okay? Let's see what I can come up with the best. You might be able to get a live, a pre-recording.
If you don't have it edited, it's going to be too choppy, man.
John, who you talking about? Not Jack Chamber, okay? Have you ever seen me treated anything like that? No, you're right. All right, come on, man. All right.
All right, everyone, let's go ahead and settle in. We're going to go ahead and get started here in a couple of minutes. I'd like to welcome you to day 3 of the Chicago Endovascular Conference. Today, we're going to be focusing more on AAA, and we'd like to welcome Dr. Krazier and Dietrich and the International Society of Endovascular Specialists. It's been a society that's been around for quite some time, and one of the has a significant prominence internationally. And it's an organization that really promotes education and the science of endovascular medicine. And we'd like to welcome them, as they will be taking over this morning and coordinating the ISIS and AAA symposium. A couple of housekeeping slides. Remember, if you're a radiology tech, you have to sign in every session. If you're a podiatrist, you have to sign in every session. If you're a physician, CME site will be open a couple of days after, actually 2 weeks after the close of the conference, but all of the details are actually in your bag. Let's see, what else do we have? Also, the pedal access course, we still have a few spots left for that. Remember, it's, we're going to have 24 cadaver legs tomorrow, and you can practice pedal artery access as well as venous access. So it's a really, really nice session. We have a few more spots left if anyone is interested. With that, I'm going to hand over the podium to Dr. Paul Jones, a good friend, partner in Chicago Endovascular Conference, and he's going to launch off the session. Thank you.
Welcome again to the CVC 2014. This is the aortic aneurysm section that we at CVC have jointly sponsored with ISIS, who is a world-renowned organization and leaders and innovators in the endovascular management of various vascular disease states. So we're certainly honored to have that partnership, and certainly with the likes of the gentleman that will soon be on the podium here. I would like to apologize. We've had a couple of unnecessary, I should not say unnecessary, but unexpected, although I feel it's unnecessary. But anyway, cancellations that have resulted in our agenda being altered a little bit. So if you can bear with us, and I assure you, with the esteemed faculty members that we have, you will find this session to be actually quite beneficial and enjoyable. And to that end, I would like to introduce our first speaker, who, when you mention the name of Dietrich, I really don't need to say anything else. It's, he has been a mentor to many of us, not only in the United States, but around the world. And I emphasize around the world. And he has been a true, and continues to be a true pioneer in this arena. And I think we are just privileged to an unlimited degree to have him as part of this meeting. So without any further ado, I would like to invite Dr. Dietrich up to talk about the topic of why has the aortic arch been such a challenge for endografting.
Well, thank you, Dr. Jones, for those very kind comments. It has been a wonderful ride I've had
over all these years and to see the development of endovascular. And as I looked at some of the program for this morning and some other cases we may be able to show you, I think the ride is not done, it's still going. This is a pretty challenging area of the ascending aorta and the aortic arch. And so I thought I would just talk about why it is so challenging, and then to show you some of the devices and techniques we have. What we're really trying to do now is move from the into the zone 0 and come across the aortic arch. And there's specific problems with the arch and the contiguous areas of that. Planning is very important, and one of the problems is there is always a discrepancy between the landing zone proximally and the landing zone distally, no matter where that is. And when you have those two discrepancies, then getting a prosthetic in there can be difficult. Dr. Jones may show us later how he took some modification of a device and was able to do that. Access is also a problem in some of these. For instance, I'm just going to show you this case quickly. This is a chronic ascending dissection with expansion. You see where the arrow is, really the entry site of that. It was compressing this false channel, and this was going to be a very difficult case with a femoral access, and so this is a possibility of using the left common carotid artery, passing the wire from that across the aortic valve. You do need to have the wire in the left ventricle when you're doing these kinds of procedures. And then you can deploy the graft down, and this is what it looks like with that kind of a delivery, and here's the postoperative study. So even though there are a lot of reasons and a lot of difficulties in dealing with the arch, with a little bit of innovation and some new ideas, you can do that pretty well. One of the other problems is overcoming systemic pressure, because you're putting a graft in the ascending or in the arch, and of course the systolic pressure is coming across that, and if you don't do something about that, a lot of different ways to do cardiac pacing. You can use pharmacologic with stop the heart, adenosine and so forth. A new concept is one we developed with a double balloon, where you can put a balloon in the superior vena cava and the inferior vena cava, and you can actually shut off the cardiac output as you deploy the graft, and that works fairly well. Now, just to go through some of the devices that are let me first of all say there are no commercial devices available for ascending and arch at the present time. Dr. Jack Blaine, who is one of the early members of the ISIS Society from Belgium, came to me 7 years ago, and he had this idea of a device that turns out to be the new Gore device. And you can see what this is. It has a little area inside where the branch can go right into that. It's taken 7 years to get that developed, but it's interesting that at the recent meeting in Charing Cross, the first 7 cases were reported. Now, there are other techniques out there, other companies working on. This is the Medtronic, has what's called the Mona Lisa. Has a similar characteristics. They've done, I think now, 7 cases. This was reported at the Charing Cross by Frank Arco. The results of these seem to be pretty good at the present time, but obviously in all these, we have to wait for follow-up to see what they're going to look like. I think at least we're getting the delivery techniques down smoother, and we have fewer problems with the early deployment. I remember we did a live case in Phoenix from San Francisco in a case where they were trying to exclude the arch and include the innominate, and that turned out to be a disaster. But these new techniques, like the Bolton relay here, I think are certainly the way to go. This is a paper recently published from Japan, and it shows how innovative these people are now in developing these devices. Most of these are still, in fact, they're all customized devices, and some are customized on the operating table, some are customized in preparation. Dr. Krause-Ivanchuk who was in Malmo and then is in London and is just retired. He presented at Charing Cross the on-the-shelf Cook endovascular arch repair. And probably there is more work going on with that company in terms of arch replacement and treatment of aneurysms than any other company. But once again, it's complicated, it takes time, and it's pretty expensive. The current prospects for total arch there are multiple other options. All these are customized, and often they will use hybrid procedures in accompany them. First of all, there are very few cases, and they're mostly single registry. There are no IDE trials, although I think there are some investigator ID trials now. Rod White at UCLA, I think, has an investigator ID trial for ascending. And once again, no commercial products at the present time that are approved for the routine use in this particular area. So I would say this is a work in evolution. Now, I'll just close by showing one area of new technology that I've been working on for the last 7 or 8 years out of Belgium. This is a multi-layer flow modulator concept, entirely different than what anything else is. This, over a period of time, causes the aneurysm to thrombose, and it preserves the side branches. They remain open. So it's a unique concept and one that we've gotten really pretty good results with in the arch and the ascending. This is the first case I did. This is a patient from Phoenix, Arizona. I flew the patient over to Modena, Italy, where I used to work 4 times a year in new device development. And this is what it looked like on the operating table. Once again, I call your attention to this wire going across the valve, because if you're coming across the arch, you really have to get that wire in there to make it work. This is a deployment. We preserve the left main coronary artery, and here's what the aneurysm looks like when it is excluded with the device. And you notice the aneurysm is excluded, and the branch vessels are open at the head. Now, this is, I think, where these technologies are going in terms of studying these patients before and afterwards. We have to get over the idea that the diameter is important. What really is important is the finite analysis of these procedures. And this shows in the aneurysm I just showed you, the finite analysis where we have high stress in the red zone there, and what we have when the aneurysm is excluded 9 months later, and there's no risk of rupture. So the technologies are not only moving in terms of the development of the grafts, but also in the technologies of finite analysis before, after, and long-term results. The conclusion I have is I think the ascending and the aortic arch will be conquered in time, but at the present time, not too much commercial in terms of being able to go to the shelf and take one off, but a lot of research going on. It's very, very exciting. Thank you for the opportunity to present this information.
Thank you, Dr. Dietrich. We'll reserve the questions at the end of the session.
Good.
Thank you very much. So the next presentation is by Dr. Venki Ramaya, a good friend of ours, from Arizona Heart Hospital and disciple of Dr. Dietrich. And the first of his talks will be on what are the risk factors for paraplegia after TEVAR in type B aortic dissection, and how can they be prevented? Venki?
Thank you, Dr. Frazier, and it is indeed an honor to be seated again here with Dr. Dietrich. And I think he'll be very familiar with all these slides and lectures, because he's been very instrumental in not only in my training, but also in putting forth and training other fellows and doctors all over the world too. Thoracic endografting has become more or less the gold standard for treating not only aneurysms, but also dissections. And as you can see here is a lady who came to us 58 years old with a large 10-centimeter thoracic aneurysm that we treated with an endograft with excellent results. As you can see, it's a huge aneurysm. And we landed the graft right at the level of the subclavian all the way down. The question you ask here is, what is the risk of paraplegia in this patient, and how do you address it? So we've had a lot of experience with thoracic endografting for almost 15, 20 years and done more than 1,500 cases so far, and even documented that in terms of how to do them, tips and tricks in textbooks and in chapters too. The dreaded complication of thoracic endografting is obviously spinal cord ischemia, and in open operations, it's as high as 10%, whereas with endografting, it is markedly much less. So there are a couple of questions that you need to answer before you discuss spinal ischemia in thoracic endografting. Can we identify the high-risk patients preoperatively? Does risk vary with the type of pathology? Is it more in aneurysms versus dissections? And the answer to that is probably yes. Is pretreatment effective? Probably not, and it's doubtful. Is it preventable? Partially, yes. Is it treatable? Partially, yes. And finally, how does it compare to the classic open repair? And I think it is favorable for sure in that aspect too. So spinal cord blood supply is actually very variable, inconsistent, and sometimes you cannot identify exactly what it is. The artery of Adamkowitz can come out anywhere from T8 to all the way down, and what is the relevance of this particular artery is also very important. But preoperatively, it's hard to determine exactly where these vessels come off and what would be the consequences if you do cover them. So which patients are at high risk? You've got to look at the collateral blood supply. So once you look at collateral blood supply, including the subclavian, the IMA, the internal iliacs, and the abdominal aorta, then you can sort of judge as to whether this patient is at a higher risk for paraplegia. Does the pathology increase the risk? And in our data, we've noticed that atherosclerotic aneurysm patients are at a much higher risk than dissections, penetrating ulcers, coarctations, pseudoaneurysms, and even in transections. So aneurysmal disease is at a much higher risk, especially the shaggy aorta with distal embolization for spinal cord ischemia. If you cover just a short segment, the risk is much less. Obviously, if you cover a longer segment, then you're going to have a much higher risk. So penetrating ulcers, hematomas, focal dissections are at very low risk for spinal cord ischemia. The shaggy aorta with aneurysmal disease is probably at a much higher risk for this. Coarctations that we treat endovascularly are also at much less risk, even though sometimes you end up covering the subclavian. Chronic dissections, also the risk is pretty low because most of the time the collaterals have already occurred. Acute dissections can present with paraplegia, especially at the onset, but once they sort of escape the acute picture, then the chances of paraplegia are markedly less. Pretreatment, steroids, there's really no evidence. Our mainstay is CF drainage, but again, these indications are not absolutely clear, and it's not routinely used in every thoracic endografting case in most of the centers. It works by decreasing the cerebrospinal pressure, it increases blood flow, and helps in preventing paraplegia. So you got to know in your protocol as to how to initiate a spinal cord drainage protocol, and we've got a protocol that's followed very closely in the intensive care unit. You keep the spinal pressures between 10 and 12, you drain 5 cc, you do not remove more than 60 cc in a 6-hour period, keep the head elevated, do constant neurovascular checks. There is some experience with steroid administration, but we use it, but the data is not very strong in terms of what is its role in preventing spinal cord ischemia. You can monitor somatosensory and motor evoked potentials during and after placement and then decide whether this is helpful or not. Is it preventable? Yes. In certain cases, especially those that you identify at very high risk, I think you can at least minimize the risk by initiating certain measures too. Obviously, the main goal is spinal cord drainage. And though it's not routinely used, I do not use it routinely on every case, but definitely in certain instances where I think it's very helpful. The other thing we learned early in our thoracic endografting experience was to maintain the blood pressure much higher. We used to, especially aneurysm patients and even the dissection patients, we used to maintain the blood pressure between 100 and 120. And then we realized that maintaining a mean arterial pressure of greater than 90 was actually much better than keeping the blood pressure low because you're covering a lot of the collaterals. The other thing you got to worry about is delayed paraplegia. And this is something that is very treacherous. In fact, there have been case reports, and we've had one patient too from Texas who complained of weakness of his legs, went to the emergency room, they fluid resuscitated him, he was a little hypotensive, and then he went home. Came back again, and the third time, he said, this is nothing, I'll just drink some fluids, and basically ended up paraplegic. So why does delayed paraplegia happen, and what are the reasons for it too? So the treatment is basically the same as the prevention. So you have to maintain blood pressure, continue CSF drainage, and rehabilitation. Obviously, thoracic endografting is markedly better in terms of neurovascular risk compared to the open report, and you can see the numbers almost in the double digits, at least initially in the experience of open repair compared to the endografting. So in our experience, we treated about 284 patients, and if you see, we had full recovery out of the 9 patients who had some neurological events, partial recovery, and we had 3 patients who had significant neurological events too. We realized that emergent is a little higher risk for paraplegic events or neurological events. The type of endograft really didn't matter, although for some reason we had the talon graft, which had a higher risk, and aneurysm disease was markedly higher risk for thoracic endografting compared to dissections too. If you look at endovascular repair and paraplegia incidence, it's about 3.6%. So overall, if you look at all of the data, you'll realize that the overall so-called risk for paraplegia is about 2.6%, and this has been confirmed in most of the pivotal trials that have been done with the Gore graft, as well as the Zenith graft and the Bolton relay graft. Here you can see in TAG trial, it was about 3%. In the Zenith TX2 trial, you can see paraplegia was a little higher, but 2 of them were permanent, but these were very, very high-risk patients and long segment coverage too. In the Talent, it was 1.8%. In the Bolton relay, it was about 3.7%. So the overall paraplegia or neurovascular risk was in the range of about 3 to 5% in thoracic endografting compared to open surgery, which was markedly higher. Again, data is there in thoracic endografting, and you can see that the risk of previously repaired abdominal aortic aneurysm is probably the highest risk factor when you're doing concomitant or combined thoracic endografting, and that is one of the highest risk factors for developing paraplegia. So we use it in selective cases, sometimes before the procedure, and a lot of times after the procedure when the neurodeficits do occur, and you've got to have a very good team that can come in immediately to get it done. So the risk factors include previous abdominal aneurysm repair, if there is hypotension, the length of coverage, subclavian coverage. In our data, we found that female anatomy and female patients were at a higher risk, and especially those female patients who had a conduit to put the thoracic endograft were probably the highest risk. So if you have a female with bad access, you do an iliac conduit who's had a previous abdominal aortic repair, that probably is the highest category of patients who will develop paraplegia following thoracic endografting. So the bottom line is, yes, there are patients who are at higher risk, as we mentioned, all the data, female gender, iliac conduit, long segment coverage, loss of subclavian, and of course, previous abdominal aortic aneurysm repair are the risk factors that should initiate spinal drainage even before the procedure starts. Thank you.
Thank you, Venki. Please don't leave the podium because you have the next presentation. What are the current indications for TEVAR in type B aortic dissection? I hope you're prepared for it.
I think so. So let's continue our talk on thoracic dissections. And this has been really challenging, and I think when we first started doing thoracic endografting, Dr. Dietrich, we felt that the role of endografting in the thoracic aorta is probably much, much better in terms of patient morbidity and mortality compared to even the open repair. So we were one of the first few to even start doing thoracic endografting well before. If you look at aortic dissection, this is a catastrophic disease, especially type A. If you leave these patients untreated, 72% will die within 48 hours, and 91% will die within a week. So there's a DeBakey classification, which basically says ascending versus descending dissection. Type 1 and type 2 belong into the Stanford A category, which is the ascending dissection, and the 3A and 3B belong to the Stanford B, which is the descending dissection. There is no controversy about ascending dissection. I know it's a big operation. Dr. Dietrich mentioned how to get a handle on zone 0 in terms of endovascular technology, but there's no controversy that acute operative intervention for type A dissection is the gold standard right now. Historically, type B dissections, medical treatment, is the gold standard. was the gold standard, and probably in most cases may still be the gold standard for now. There are certain indications to treat type B dissections, and this is where the controversy is. There is no controversy in terms of these indications. If there is a progression of dissection, if there's an impending rupture or a contained rupture, severe hypertension that is not controllable, increasing pain that is not controlled with pain medications, if there's a localized false aneurysm, there is some degree of end organ ischemia, and you have the false lumen enlargement of the aortic diameter of almost greater than 5 centimeters, then you're justified in treating these patients. And these are basically the indications, even today, for treating these patients with endografts too. So endografting has a big role in treating thoracic dissection. There's no doubt about it, because if you compare it with open surgical repair, you will see that the mortality is 35%, and if you have a patient who is symptomatic with malperfusion, mortality from open repair is 50%, which is significant too. So the discussion is basically about what do you do with patients who are asymptomatic? And that's where the controversy is. And there is data coming around that there may be a subgroup of patients that we can identify who are at high risk, and those can be treated endovascularly even though they are asymptomatic. What happens to these type B dissections? There is aneurysmal dilatation in a lot of these patients in almost 30 to 50%, and a mortality of 25% within 3 years. So the basic philosophy is if you shut the entry tear, you redivert flow mainly into the true lumen, there's a high chance that the false lumen will thrombose, it'll improve visceral circulation, the pressure in the false lumen reduces, and mesenteric ischemia will be markedly less, perfusion will be better. And that is the whole fundamental principle of treating type B dissections endovascularly. One thing we've learned at Arizona Heart under the tutelage of Dr. Dietrich is to do intravascular ultrasound. And I think if there is one role of intravascular ultrasound in these patients, it is basically in dissections. You do not know where the true lumen is, you do not know where the false lumen comes out, whether these visceral branches come off the true and false. Is that what you're playing? So this is an example of a patient who came, 53-year-old, came in with an acute type B dissection, was symptomatic, going into renal failure, abdominal pain, and not moving his one leg. And you can see now we got 2 wires. One pigtail is in the false lumen, the other one is in the true lumen. I will skip this video because, so basically you have to go in, find out where the true lumen is, and IVIS will help you, as you'll see in one of the next pictures. IVIS will help you exactly where to determine the true lumen and the false lumen, and hopefully guide your wire following the IVIS. So this patient was treated with an endograft. This was one of our earliest cases, and you can see we sealed him completely. The other debatable point is, how much do you cover? Do you just cover the entry tear? Is the false lumen unpressurized if you cover the entry tear and there is no compromise from pressure through the visceral branches? So that's the whole question in thoracic endografting. So the technology, the principle is very, very simple, but they also go on to develop chronic dissections. And what is the role of thoracic endografting in chronic dissections? And that is only because if there's malperfusion, hypertension because of some sort of impingement on the renal vessels, or enlargement of the thoracic aorta aneurysmally. And these can be very, very complex. Here's a classic case that I think my colleague, Dr. Rodriguez, did. And you can see you have to determine what is feeding what, the true lumen and the false lumen, and especially in this particular patient who had a previous tube graft for a thoracic aneurysm and then dissected. So you got to do the angiogram, this 3D reconstructions, the intravascular ultrasound, and even an intravascular ultrasound along with the TE. So you can see at the lower corner is the role of the intravascular ultrasound, which will clearly tell you the true lumen, the false lumen, and the branches that come off which lumen accordingly. TE is very helpful, especially in aortobronchial fistulas, if you can manipulate them. So the technique in this particular case was basically to do wire manipulation, fenestration, balloon angioplasty, and then put an endograft from the previous endograft into the true lumen all the way up to the celiac artery. And these cases can be very, very challenging. The third aspect to dissections is what happens to the visceral branches. And sometimes you can just treat the visceral branches depending on whether this is a dynamic or adynamic sort of a obstruction to the visceral branches. And you need not treat with thoracic endografting, but you can just treat the stented segment or the affected segment with a stent and prevent hypertension problems too. So angioplasty with septum fenestration is a good technique for those patients who do not have aneurysmal disease. Open surgery, mortality is very, very high compared to endovascular repair, and you can clearly see that the 30-day mortality for type B treated with stent grafts is only 5.3, paraplegia rate is 0.8, and technical success is very, very good without any major complications. So I'm going to go a little fast in all our experience. As you can see, we've been doing this for many, many years. There was a very elegant study that Dr. Rodriguez and us did regarding what happens to the true and false lumen. It has been published in the Journal of Vascular Surgery, and you can see that what we've done is basically measured the dynamics of the true channel and the false channel, and basically calculating what is known as a true lumen index and the false lumen index, and seeing what happens to these. And we found that if you completely cover the entry tear, which is the goal, then your results are markedly better. If you completely cover the entry tear and create thrombosis of the entire false channel, that is the best results that you'll ever get. So we've done a lot of these patients. We've used a lot of endografts. Most of these grafts were with Gore early in our procedures. We had a paraplegia rate of 1.9%, which is very, very small compared to open repair. And we've been following these patients for almost 2 years. And I'll come to the conclusions as to what exactly we found in these. We found that proximal thrombosis of the false lumen in the proximal 1/3 was occurring in about 73% of the patients, mid thrombosis in 70%, and complete thrombosis of the false lumen without evidence of antegrade or retrograde, which is probably the ideal situation, occurred in about 33% of the patients. So, successful treatment, you have to cover the entry tear. Antegrade flow is the main source of aneurysmal dilatation, so you should not get an antegrade leak. You cannot really completely repair the retrograde leak. It's not really a leak, it's retrograde flow. So if you look at all of our data, we'll see that there will be retrograde flow in these patients from the celiac and the SMA, but it depends on what the pressure in the false lumen is. And we control that by measuring the size of the false lumen as it progressed over the years. So covering the proximal tear resulted in shrinkage of the false lumen within 6 months. But in chronic cases, it takes much longer because of the septum. Malperfusion is improved by placement of the endograft. So you don't really have to go in and do fenestrations now, which we used to do in the past. You just go in basically and treat the entry tear, and that automatically increases the perfusion distally. Endoleak is basically antegrade flow. If you say in thoracic dissection there's a leak, it basically means there is an antegrade flow and not retrograde flow. So in conclusion, remodeling changes are really good if you completely seal the entry tear and thrombose the false lumen. So what about uncomplicated dissections? These occur less than 14 days. The primary entry tear is distal to the subclavian, and then there are no symptoms in this particular patient. So the INSTEAD trial was the one that basically tried to identify whether endografting is better than open repair or even best medical management. And if you look at the summary of the INSTEAD trial, at 1 year, a slightly higher but not statistically different rate of mortality was observed in the stent graft arm. And the conclusion from the INSTEAD, at least at the end of 1 year, was that antihypertensive optimal medical therapy is probably better with deferred stent graft implantation. So that was the conclusion. But as you go over all of the data that's now coming out, you'll realize that after 5 years of the INSTEAD trial, this was 2-year data, which basically showed that the true lumen increases, the false lumen decreases, and the size of growth is markedly decreased over a period of time when you do thoracic endografting. At 5 years, you'll see that patients treated with endografting did markedly better, not only in terms of complications, but also in terms of overall therapy, in terms of decreasing and survival with the thoracic endograft arm, basically. So at 5 years, the mortality for medical treatment was 31.2 and 16.3% for those patients treated with an endograft. So basically, the trials are suggesting that there is a subgroup of patients who should be treated with thoracic endografting, and I think we still need more data, because we've had a subgroup of our own patients who we treated with soft signs, basically uncontrollable pain, uncontrollable hypertension, no real malperfusion. And those patients were actually the best cohort of patients that we treated whose false lumen almost completely disappeared. And sometimes we tend to push technology, but I think the authors concluded, even in the INSTEAD trial, that TEVAR, in addition to optimal medical treatment, is associated with improved 5-year aortospecific survival and delayed disease progression. So the work is ongoing. There are different techniques like the petticoat technique and everything else. So patients who may benefit from early stent graft intervention are these patients, basically, even though they are not complicated. And you can make a case to treat these patients early with thoracic endografting rather than best medical treatment. You don't have to cover the entire thoracic graft nowadays. You can just treat the entry tear, and if there is any evidence of malperfusion or the true lumen being suppressed, you can just put regular stents. That's called the petticoat technique. So with all of these, I think thoracic endografting for uncomplicated thoracic dissections will eventually come out as the way to go in special high-risk patients with uncomplicated type B dissections. Thank you.
Thank you, Dr. Amaya, for that very extensive survey of dissections and presenting the long-term data from the Institute. Is Paul Jones in the audience here? Is he not here? Okay, we'll put him off. If we could have Mark Woolley's slides up, please. Mark, would you please come up? You're going to talk to us about predictors of complications after EVAR.
Okay, thanks very much, Ted, and thanks for having me. I've always enjoyed this meeting. So let me give you an idea. I guess this is our controller here. Okay. Predictors of complications. I wish I had the answer to this. Where should... Yeah, I got it here. All right. So basically, EVAR device is currently in place. You can see here Gore, Endologics, Lombard, Medtronic, Cook, Nelix. None of them are free from some form of complication. Fortunately, it's minimal. Now, when we look at the evolution of repair, you see open surgical repair is then traversed to ER with surgical cut down, and now surgical cut down is not totally antiquated, but it's becoming replaced by percutaneous, and you'll hear more about that in the sessions. But when we look at the overall event rate, compare surgery, 30-day mortality, 30-day major event rates, and length of hospital stay, clearly the EVAR has totally replaced surgery from those standpoint, especially hospital stay. Patients now possibly going home the same day, certainly no longer than 1 day. So clearly there's an advantage in that. So when we look at the re-intervention rates at 1 year, you can see the re-intervention rates for ovation, 6.2%, 6.7% for Endurant, 11% for Cook, and 9.9% for Endologic, and Gore excluded 11%. So basically everyone's in the 5 to 10% range for re-intervention, and most of those re-interventions are endo leaks. So when we looked at the causes of the type 1 endo leaks, which are the only really leak we're seriously interested in, the question is it anatomical, is it device failure, or is it stent migration? Ordinarily, it's stent migration or device failure. Anatomical also critical, and I'll show you a couple examples. So proceeding then, what do we worry about in predicting complications? We worry about constantly the neck morphology. And then secondly, with the iliac access is also critical, especially for the 18-24 French systems. And distal seal attachment sites in the iliacs is also critical. What's more critical in some than others, and it's critical in ovation. And pararenal aneurysms getting into complicated situations with fenestration. So when we look at the self-expanding stents at the neck, we say, well, what happens to the neck actually over time? So outward force is no question. We know so much about outward force now with all the peripheral stents, so we think translate that same information to the aorta. We know that proximal stents oversized at the renals over a period of time have to expand just from outward force of the stent. And so you can see in this animation, proximal stent oversized, and then secondly, you can see the expansion occurring in the midsection, and then neck dilatation occurring in resulting in a type 1 endoleak. So we think probably we haven't given enough attention from the engineering standpoint and the design of the stent to outward force. So outward force has to have compressive resistance to maintain some time of equality, compressive resistance, balancing outward force. So that's an engineering thing. What is interesting about endoleak is this, and Frank Corrado raised this question, is endoleak the right word? And with all credit given to a great guy, Jeff White, who passed away prematurely, really designed the word endoleak. And this is also a case that Frank gave to me. You say, well, most often this is a type 2 leak. It's not very obvious. So the question is, ambulatory imaging centers with radiologists and or cardiologists who really don't have inside information on managing aneurysmal disease, reported this as an endoleak. And the first thing they do is they call a primary care doctor or call a family. And in this situation, they say call the ambulance. And so, as a result, all this confusion, actual story, all this confusion resulted in the ambulance, and then the police take the patient to the hospital, and they repeat the CT scan, and the vascular surgeon says, it's nothing more than a type 2 endoleak. So it raises the question, it bothers them to me also, because it happens to every one of us. They call a primary care physician, and a primary care physician thinks you've made a major mistake. You say, no, it's only a type 2 leak, nothing to worry about. So the solution possibly we're looking at in terms of the solution to the endoleak might be the Nelix graft, and I was involved with Nelix from the very start. So Nelix we thought was a total failure when we initiated, but now it's a game changer. And Nelix is nothing more than these 2 sacs, balloon expandable, controlled, and you can see the sac expands to occupy most of the aneurysmal site. So we think that at least will control partially the type 2 endoleaks. That was true in this smoke trial that they did of 27 patients when I was there, and we had no endoleaks of any significance. And you can see the Nelix here. So Nelix has possibilities. It's a little cumbersome, but I think if type 2 endoleaks is a situation, it's definitely worth a try. So basically, it's nothing more than a cobalt chromium alloy, standard stent material. They're balloon expandable, and it creates two lumens, highly flexible, it's crush resistant, and it incorporates into this sac, and the peg is put into this sac, and the sac then expands and goes into the aneurysmal wall. So I'm predicting a type 3 endoleak. Obviously, all the type 3 leaks, the absolute intervention necessary, no question about that. And you can see this iliac aneurysm here that was overlooked in follow-up. And then obviously you can see the rupture here distally, and it required nothing more than an extension of the limb, and the limb was put in, and obviously there's no further endoleak. So situations like that are caught quick enough, have not been an issue. So this is another interesting example of ignoring a type 3 endoleak. And you can see here, this is a normal graft, no endoleak whatsoever on follow-up. The patient disappeared to follow-up, came back type 3, strongly suggested, as you can see on the 3D reconstruction of a CT scan. You can see the endoleak, and obviously on the axial images, a significant endoleak. Doesn't look like IMA because you don't see the IMA there, feeling. So obviously type 3 was suggested. One more day went by, patient was ignored, and patient collapsed and died while being transported to the OR. So type 3 endoleaks just have to be treated instantly on recognition. Here's an endoleak that we saw on a 1-year-old follow-up. It's a fairly big endoleak, but it's encapsulated. And you can see here, you can see there on the medial side there, you can see a little blush there. It's more than a blush. And this is an acutely angulated situation where we deal with migration and leak. And in this situation, we also had a problem with an 18 French going into a 5mm vessel. So we had to leave the 18 French sheath here proximally in that external iliac, and then deployed the cuffs up at that point, and then blew them up with the cuffs. And we put 2 cuffs in. You can see the acute angulation still stayed in spite of the 2 cuffs, but nonetheless, we controlled the endoleak. So again, just showing you acute angulation, difficult, frequently resulting in endoleaks, even in spite of the fact we're reinforcing with additional cuffs. Also, tortuous iliacs like this present major problems. You can almost predict complications either at the iliac site or certainly if it leaked later on, but all kinds of difficulty going there. Fortunately, with a low profile, we can actually leave the sheath in the external iliac and deploy from there. And again, migration very likely to occur with these acute angulations. So the question was, are these really worth doing, or should we go to surgery? This is a patient we saw here recently. So there's a huge endoleak here in the central between those 2 limbs, and the limbs actually have come out of the common iliac, and now they're free in the aneurysmal sac. So we have a major endoleak here on the follow-up. In this situation, we relined the sac with 2 gore limbs extended. You can see that come down the internal iliac. When we had these sheath, this is ovation, we had the limbs were on the internal iliac and they come out. And now you can see, obviously, we have relined, but you can see, obviously, the acute angulation and the stenosis in the right external common iliac junction. So we stented that as well. And now we have satisfactory flow bilaterally, no endoleak, and the patient doing fairly well. Okay, unfortunately, this is a video, and it's embedded, so we couldn't run the video. This is ovation. And on the left, you see the limb, and the limb is coiled up, and it's only 11mm lumen on the ovation, and it was almost impossible to catheterize this, almost impossible. So finally we come from the brachial, we came from the right side, we came from the left side, because the limb was twisted on itself, and it's impossible to pass. We finally got an 014 choice B2 through there. We put a microcatheter into it. Then we exchanged for 035 wire, blew up the balloon, let the balloon down. Limb went back right up into the position there. So the only way we did that, we put an Amplatz wire in and ballooned it and took the balloon out right away and put the cuff in. Of course, we got away with it. But you can see there on your left that it's coiled up there. And once that's coiled, you can almost forget about recanalizing it. So the interesting thing with the Ovation is that it works fine, but you cannot manipulate the sheath, because once you rotate the sheath, you rotate the gate. So endoleak, Achilles heel, no question about that. Avoidable, some of them are avoidable, some of them are unavoidable. And here again, showing a rupture of the common iliac, but fortunately in this case, early on, we used to monitor most of ours from transbrachial. So we have the transbrachial catheter in there. So when that happens, it's not a big event. You just simply blow up the balloon control with a 26 balloon and put a stent in there. But now, I don't think very few people are monitoring anything from the brachial, and we're no longer either, but that certainly was a lifesaver, otherwise this patient would not have made it. Again, finally, surgical repair for this complicated ruptured aneurysm, and again, showing you the major complications. So in summary, I think that the endoleaks are a major problem, especially the 3s and the type 1s, and we treat those urgently. Thank you.
Thank you, Dr. Woolley. That was a very nice presentation. We're going to change the order a little bit and make our debate the last session. And so I'll call on Dr. Krazier, who's going to bring us up to date on a really new technology. It's very exciting, the endo anchors. Dr. Krazier is one of the, I think, PIs on that.
No, I'm not a PI, but I'm a believer.
You're a believer? Okay, thanks.
Well, while they're looking for the slides, I think it's very appropriate to continue with this presentation, because Dr. Woolley mentioned how difficult and challenging it is when you do EVARs in challenging anatomy and you have problems and complications. One of the most challenging things is, and there will be debate shortly after this, and it's very appropriate to give this presentation before, when you have challenging infrarenal neck anatomy, or when you don't have any neck, or you have juxtarenal aneurysms, what to do. Here are my disclosures. I don't think anybody's interested in it. So we all know from multiple publications that hostile proximal neck challenges EVAR durability. There's no doubt about it. And a lot of us do procedures outside of IFUs and then have to deal with this type of issue later. So among some of the more important publications is this meta-analysis by Antonioni, who looked at almost 1,600 patients, and he divided them in two groups: patients with challenging neck anatomy and patients without challenging neck anatomy. And you can see here that a variety of stent grafts were used in this analysis. What he found, and that has been also found by other investigators, that type 1 endoleak was 4.5 times more likely to occur after endograft implantation in patients with hostile proximal neck anatomy versus normal anatomy. Not only that, but aneurysm-related mortality on long-term follow-up was 9 times higher in this subgroup of patients. So we know, as far as the predictors of type 1 endoleak and also need for reintervention, are short infrarenal neck of less than 15 millimeters in diameter. You can see this from multiple publications. And also tortuous angulated infrarenal neck. And as I mentioned, more and more cases are being done with challenging infrarenal neck anatomy, because everybody is doing nowadays EVARs, and for us that have been doing it for 20 years or so, most of our patients are referred with extreme challenging anatomy. So one of the approaches, and Dr. Woolley showed you several approaches how to treat those problems or how to prevent those problems, is using this device, Aptus Endo Anchor System, which is indicated for treatment of problems with endografts due to migration or endoleak, or in patients that are at risk of such complication. The device consists of this HeliFX guiding catheter and then a plier, and the endo anchor that's made out of alloy. It's 0.5 millimeter in diameter, and it's 4.5 millimeters in length. There are two systems available. One is for EVAR, or abdominal aortic aneurysm exclusion, and there are, as you can see, different angulations available. It's a 16 French delivery system. And then there's a thoracic, also HeliFX system, that has 3 different configurations depending on the size of the aorta or the aneurysm. It's larger in diameter, it's 18 French OD. And this device has been extensively studied, bench tested, and also in clinical studies, and has been found to be compatible with a variety of stent grafts such as Zenith, Excluder, Anurex, Endurant, and Talent, and some other ones are being studied for further applications of this device. So if we ask ourselves which patient can benefit from endo anchors, you have a variety of scenarios. Obviously, prophylaxis is one of the more important scenarios, such as hostile neck anatomy, due to a variety of scenarios that we already mentioned before: challenging, short, angulated, funnel-shaped neck, calcified neck, thrombus, and so on, and the difficult landing zones, such as, let's say, bird beaking and thoracic aneurysm, and so on. But also, there are important scenarios in normal anatomy when patient has comorbid conditions and is not a candidate for surgery, and we want to make sure that this patient doesn't have to come back for a secondary intervention. And a patient that is unreliable or cannot come for follow-up, and also in young individuals that will need prolonged follow-up for many years. And then treatment of complications and problems with proximal seal, such as acute type of 1 endoleaks that occur during the intervention, or late type 1 endoleaks, or migrations, or combination of the above scenarios. Here I would like to share with you some of the cases that we have done at our institution. Here's a patient that was de novo and had a very short neck, as you can see here. There was a very small type 1 endoleak there that possibly could close by itself over a period of time, but with availability of endo anchors, we didn't take chances or didn't take risk, particularly because this patient was on Coumadin, and those patients are more likely not to thrombose the endoleaks. So we put 6 endo anchors and resolved the problem at the primary procedure with good results. Here's another recent patient we have done with very tortuous and also short and calcified neck. You can see a small type 1 endoleak, even though the endograft conformed very well to tortuosity. Again, nowadays we don't leave those alone, and we treat them and place endo anchors and resolve the problem. One of the more challenging and troublesome scenarios is endograft migration, such as in this Anurex stent graft and type 1 endoleak. Of course, the best option is to place the aortic cuff to extend this device and then anchor the cuff below and above with endo anchors and resolve the problem of type 1 endoleak and migration. Here's one very recent case that we've done about 3 weeks ago, a patient of traumatic disruption of the aortic arch that, as you can see, involved both left subclavian and also left carotid. And we treated it with a stent graft that we extend all the way to the innominate, and also we chimneyed the left carotid this downward, and also the left subclavian, and then used endo anchors to fixate the stent graft because the seal zone was less than 1 centimeter. With, as you can see, excellent result. You can see both chimneys to the left carotid and subclavian. This was done percutaneously and under local anesthesia. So to evaluate the anchor device long-term results, Aptus initiated this registry, which is worldwide registry, for both primary and revision type of cases, and there will be 1,000 cases in each group, followed for 5 years. Over 400 patients have been done already until June of 2014. As you can see from this preliminary data, for both primary and revision cases that almost all of the cases were due to hostile neck anatomy in both groups, in primary and revision as well. And also the necks were very short as well in both groups. As far as the results are concerned, you can see that in primary had a success of 92% as determined at the time of the procedure with no evidence of endoleak. In reversion, the results were a little bit lower, about 86% resolution of the endoleak. But again, this is just the procedural information. And you can see a lot of those patients, about 50% required cups because of the challenging anatomy. Most of them were done in revision type of scenarios. Now, when we compare the anchor results on long-term basis, and the information is available for 13 months in anchor registry, you see that the incidence of endoleak in anchor registry was only 1.3%, while in Antionu meta-analysis it was 9.8%. That was cases treated with challenging neck anatomy without the use of endo anchors. And over 2,500 cases with endo anchors have been done for both the thoracic and abdominal, and most of them are for abdominal, as you see, and typically it's done for primary scenarios, a little bit less common for revision scenarios, with a variety of devices, but the most common ones were excluder and endurant, which are compatible with this device. There are certain limitations as far as endo anchors are concerned, such as mural thrombus, porcelain aorta, or inadequate endograft apposition to the aortic wall. So in conclusion, we can say that major EVAR studies revealed that there is a durability limitation in patients with challenging anatomy, and proximal seal stability remains the key. Endo anchors are definitely beneficial, not only in EVAR, but also in TVAR, to prevent both acute and late type endoleak. And so far, there is no evidence that type 1 endoleaks appear at late follow-up at 5 years of follow-up. And there is more than 90% acute success in revision in anchor registry. So HeliFX demonstrates safety and efficacy in more than 2,500 patients that have been treated so far. Thank you very much for your attention.
Thank you, Dr. Kraser. That was a beautiful arch case where you demonstrated that what I was talking about, using the hybrid approach, where you were able to come through the arch vessels. And now you add another component, the anchors. So we're getting more and more technology to conquer this area, as I said earlier. What we'd like to do now is go to a debate format. This should be a very good debate because I don't think we have the answers to this. One, Dr. Mark Wilson is going to say that the best way to treat these is with fenestrated, and then Dr. Amaya is going to come back and say you don't need fenestrated, the snorkel is better. So, Mark, we're looking forward to your giving us your idea.
Thank you very much, Dr. Dietrich. It's really an honor to be part of this very distinguished faculty, and I thank Dr. Jones and Dr. Goldzar for inviting me. Well, we've already heard from Dr. Kraser that extending the, pushing the envelope for complicated and hostile necks leads to MAEs and more problems later on in terms of higher type 1 endoleaks, secondary interventions, and also higher 30-day mortality rates, as was mentioned in that 2013 JVS article recently reviewed. And of course, out of necessity, people are pushing the envelope, obviously, and prior to having access in the United States to a fenestrated custom-made endograft, which was approved by Cook in 2013, for a few years, people have used existing devices, existing infrarenal aortic devices and stent devices in order to create the so-called chimneys or snorkels, and basically to elevate the seal zone and avoid the complication that we've seen with hostile necks and current device for infrarenal applications. So this is the debate here between those two technologies. And let me tell you right off the bat, this is not we're not going in a ring where I would lose. We're not going to put boxing gloves on. I think this is more of an informative comparison of data available and trying to guide you in terms of where does one technology may be placed in your patient selection processes. Now, the chimney graft or the snorkel graft was coined by late Dr. Greenberg in 2004, who described the technique as a bailout strategy. After inadvertently covering a renal artery, he was able to get back into the renal artery and put a small stent, and this is how this technique was described. But of course, over the years, it has evolved, and people have really pushed the envelope here to intentionally relocate the existing grafts higher than the renal or the visceral arteries and creating a seal zone with off-the-shelf existing devices. And this is how the technique is performed. The main device obviously comes from the groin area, but you also need access from the arm, sometimes both arms, depending on your techniques and your strategies. But if you're going to be snorkeling two renal arteries, you obviously need two sets of 6 French sheath that have to be entered into the renal arteries. And there's a variety of techniques. I'm not going into the techniques, quite frankly, but keep in mind that these devices, they're not really engineered for that purpose. So we are really trying to finesse a procedure here that has not been completely scrutinized by the appropriate authorities. We're sort of taking devices off the shelves to try to get a better seal. And there's different stents that people have used, atriums, Viabonds, and so forth, and I think there's a role probably for all of them. It takes obviously a lot of planning. It is technically challenging because of the upper extremity access. Sometimes can be difficult, particularly in tortuosities and whatnot, but the technical results have been very good early on and very acceptable early, less than 1 year result. In fact, one of the first series that came out in the literature in 2012 by Jason Lee from Stanford, they reported on their experience with 56 snorkels in 28 patients for a variety of visceral snorkeling. Their technical success was very high, 98%, 30-day mortality, 7%, but the mean follow-up was less than 1 year, but still they reported a very acceptable patency in terms of the chimneys and whatnot. And this actually further created the enthusiasm that already we had and thought this is really going to be a good technique. And in fact, in their report, they looked at the literature and all the authors reported very similar results with the early technical success and the 6 months patency results. A little more recently, a review of 16 reports, including 93 patients, basically confirmed the same thing. With a variety of stents used for chimneys, they achieved acceptable technical success and short-term patencies, but there was still a type 1 endoleak of about 10-15% that we weren't really paying much attention to, but these complications can certainly happen. And of course, type 1 endoleaks are the Achilles heel of snorkeling techniques. This has been recently reported, where the technical success was fine, but 2 years down the road on a follow-up CT scan, you can start seeing type 1 endoleaks occurring at the side of the snorkels due to modifications of the gutters and reforming that can serve as a path to refill the aneurysmal sac. So this is a problem with the technique. Now, in fact, more recently, not quite published yet, but available for review on the internet, this is a retrospective study for 4 years from Gainesville, 41 patients with the chimney techniques, and they started raising some concerns. They found that 13 of their 41 patients did suffer a major adverse event. Chimney stent thrombosis, type 1 endoleak in follow-up reintervention, 30-day mortality, and GFR modifications in follow-up as well. So they raised some concern and didn't say, don't do this, but on the other hand, they said, start thinking about, what really are the strategies here for this technique. Now, the Cook device became available in 2012. It's a custom-made device, so it cannot be used in emergencies, and that's a shortcoming of the device. And on top of that, 20 to 30% of patients do not qualify for this technology because of aortoiliac disease, tortuosity and whatnot, or inadequate seal zone. So there's a variety of neck issues that need to be really pre-planned in order to select patients strategically. And in fact, the planning process is very tedious, it's time consuming, it requires significant preoperative planning, and you need to have access to higher resolution, reformatting software strategies in order to submit all these variables to the Cook, Australia plant where the device will be manufactured. Now, this is an interesting study that came out since FDA approval in 7 United States centers. So these are people who obviously had a lot of experience, but of interest. Over a 6-month period, they reported 57 patients with 100% technical success. And in fact, the majority of the patients they reported on actually would not even have been selected for the US fenestrated trial that required at least a 4-millimeter neck in order to be enrolled. So they're pushing the envelope a little bit in these patients, but in spite of that, they didn't see any type 1 endoleak, but it's not a long-term study. Now, there's a lot of literature, and I'm not going to go through all this, but in general, for fenestrated EVAR, recent studies and meta-analysis have shown very good early outcomes, with a 30-day mortality ranging from 2 to 4%, and excellent long-term results in terms of durability, freedom from any reintervention. However, most of these data represent single high-volume institutions and registry data where careful patient selection protocols really have been done. So this is not really real-life data, quite frankly. Now, what about surgery versus fenestrated EVAR? Well, there's no randomized studies, I'm sure you know, in the literature. However, in this study here, where they have done a retrospective propensity match comparison between FEVAR and open surgical repair, and the propensity allows you to have the populations that are more comparable in order to make it more valid. But note that the 30-day mortality complication was 9.5% in the patients who had undergone fenestrated compared to just 2% in the operative arm. So, you know, these procedures, you really have to have the extremely good surgical skills. You have to be able to assess a patient very objectively, I think, to determine whether you should go with an operative strategy or even a fenestrated strategy. Now, what about comparing the 3 methods? This is a retrospective PubMed data search review, 20 studies for open surgeries, so close to 2,000 patients, FEVAR, 10 studies, 1,000 patients, and only 94 patients for chimneys, just because the data is somewhat lacking. But of interest, I will tell you that if you compare the 3 outcomes of renal impairment, stroke, and early proximal type 1 endoleaks, you will see that there is a higher risk of having a renal impairment in the operative arm, which has to do with suprarenal clamping, reinsertion of the renal arteries and whatnot, but also notes that it seems to be a little bit higher also in the chimneys compared to the fenestrated grafts. Now, stroke is a complication that will only occur, or I shouldn't say only, but it's a risk in passing catheters and devices, obviously, through the aortic arch. But the type 1 endoleak is 10% versus 4.3%, comparing chimneys versus fenestrated. And in fact, this is a paper that was recently published. That's interesting. We know there's a problem with chimneys, and people are trying to remedy to this with all kinds of innovative tactics. This is an endo stapling in vitro rendition here to try to better tack down the gutters and avoid the type 1 endoleak complications. So in conclusions here, where are we in 2014? I will tell you that the chimneys, they do play an important role in our strategies, but you really have to have an algorithms to allocate the patients to the right form of procedure. When patients have a comorbid burden for open repair, and when a ZFEN is excluded for a variety of reasons that I've already talked about, then it should only become a bailout solution in those very difficult, complicated patients. Thank you very much for your attention.
Thank you very much, Mark. Okay, Vinky, we're anxious in getting your comments about this.
Well, first of all, I'd like to thank Mark for presenting really good data on chimneys in the first 5 minutes of his talk, and then concluding that chimneys are a good, viable option for these complicated patients. So that basically ends the debate. Oh, can you move the debate talk, please? This is the debate one. You may have to call speaker prep room. That's what I said. The debate has ended with my few statements. You may have to call speaker prep and tell them to load it because this debate was supposed to be after the break. Call speaker prep. He may have not uploaded it because it was after the break. So, I'll give you a rupture talk. So, well, these are complicated cases. And as Dr. Dietrich said, there are no true winners in this. But the bottom line is, when you get technology that treats these complicated cases, the ideal method of any technology should be that it's easily available, easy to use, less expensive, applicable to most anatomy and morphology, and have long-term data to prove that this technology works. And chimneys are not there yet, and neither is fenestrated. So it's very difficult to compare apples to apples and oranges to oranges, comparing fenestrated versus chimneys. And if you look at most of the chimney cases that are done across all of the studies, you will see that the chimney cases were done in those patients who actually could not really qualify for the fenestrated. So obviously, this subgroup of patients is a very highly technically challenging group that do not even meet the criteria for fenestrated. So that in itself tells you that the chimney technique is definitely a viable option for these complicated patients that don't even fit into the protocol for fenestrated. Obviously, the technology is not there yet to prove that chimneys are better or equivalent. But the concept is what attracts everybody to any kind of technology. Once you have a concept that is sound, you can always build a product to meet that goal or that concept. And I think chimneys will markedly change the way these complicated cases are handled eventually. With the current technology of NELEX, where you fill the entire aneurysm sac, or even trivascular, the ovation stent graft, where you're injecting polymer or manipulating the endograft from the outside, the role of chimneys may be a better way to go than fenestrated grafts. Mark Mewson presented fenestrated grafts. And Mark, I think your talk was full of holes, just like your grafts. So chimneys, one, advantages. Off the shelf, most important, easily available, less technically challenging. Yes, long-term data is not there, but we've treated about 40 patients. We are writing up our data on these chimney patients. So if current technology expands with the concept of the NELEX and the ovation grafts, you can cannulate all of these branches and then put the endograft and seal the gutters. So the potential to improve chimney grafts with the current technology of NELEX and ovation will probably be much easier to treat these complicated patients, and that's where I think chimneys will always have a role in treating these patients. I can show you data on a huge amount of studies that even Mark has basically replicated in his data, that chimneys still do well. He himself stated that at 1 year follow-up, the technical success is very good. He showed 2 patients with a type 1A endoleak who probably would not be able to be treated any which way endovascularly, very high-risk patients who eventually ruptured and died. But if you look at all of the data, and I can quote at least 15 papers, where chimneys have been done right from Korea to India to Japan to America, all of the big centers, unlike UCSF and Cleveland Clinic, where most of them are done fenestrated. So this technology basically says that it can be available worldwide. is much easier to use, and can be treated in a host of complex patients that do not even meet the criteria of fenestrated. Fenestrated is very technically challenging. It takes 6 to 8 weeks to make the graft. The graft still is made in Australia. It takes 6 to 8 weeks, so patients are waiting. It's not easily available. It's done only in a few single centers, and the technology is not up to par as yet, even though these 3 centers that do a majority of them have done really well in terms of propagating or in terms of pushing the fenestrated technology. The concept of chimneys is very intriguing, and I'm sure we can build on this concept with current technology of filling the sac with polymer and manipulating the graft from the outside to make chimneys, seal the gutters, and eventually make this a better viable option to treat these complicated patients than spend 6 to 8 hours trying to cannulate fenestrations, small fenestrations, big fenestrations, and scallops in the future. So with those few words, I will accept the victory. Thank you.
Vicky, before you sit down, Vicky, let me just raise one point, because you saw several of these references to the Journal of Endovascular Therapy, and you have copies. And in reviewing these fenestrations, I notice when they present the complications, often they don't present the spinal cord ischemia.
Right.
It seems that for some reason that column is left
It's always
out. And-
it's always written as NA or non-applicable, and that's one data set that has not been shown in fenestrated grafts, even though they've shown stroke evaluations and stuff, but the incidence of paraplegia could be markedly much more in all of these, with the manipulation within the aneurysm sac, with cannulating the fenestrations, dislodging particles. And the biggest factor for fenestrated, we took part in fenestrated in 2005, and now the technology has suddenly come out, is always those branched, those fenestrated stents. The aorta is a very, very dynamic organ. And so these fenestrations, especially the stent that goes into the celiacs and the SMA and the renals, always tend to fracture or tend to close. And that's where the technology has to improve in fenestrated.
Well, I think it's time to ask the audience to judge our 2 debaters. They both did a very, very good job. So let's have the hands of those who, at the present time, would favor the fenestrated graft. Well, we got a couple, 3. Okay. How many would favor the snorkels? Okay, I guess the snorkels are going to win. Okay, good.
Debate I won without showing a single slide.
You don't even need any slides to win.
All right, so if you did not have enough of Venki Ramaya, there is more to come, so enjoy it. Venki, go ahead.
Thank you. So we go into another avenue of vascular surgery that has seen a market shift, almost a paradigm shift. 2 things have happened in the world of vascular interventions. One is the market advancements and limb salvage that occurs in critical limb ischemia, and the second is making a dent in the mortality and morbidity of ruptured abdominal aortic aneurysms. And a lot of this has to do with endovascular approaches. Dr. Dietrich may remember this, and I think it'll bring very pleasant memories, because this thing has stayed in my mind. I hope it plays. This thing has stayed in my mind for almost 20 years, probably. This was a lady that got flown from Colorado with almost an 8, 9, 10 centimeter aneurysm. Couldn't be treated anywhere else, because she also, I think, was a Jehovah's Witness too. And then she came into Arizona Heart, and those were good days, Dr. Dietrich. We sealed this aneurysm in 15 minutes with the clock running. And she did really, really very well. Unfortunately, the video is not playing, but let's go on ahead. So open repair of abdominal ruptured aneurysms. This is what it looks like. I think when Mark Mewson would be a surgeon and would be doing open repairs, this is what he would look like, and this is what he would be doing at the end of the case. And that's the scenario of doing open ruptured abdominal aortic aneurysms. It's a mess. On the other hand, when you do percutaneous endovascular repair, the risks are the same. The patients are very high risk, but at least you don't have blood spilt at the ceiling and the floor. Ruptured abdominal aortic aneurysms is a very, very high morbid and associated with a very high mortality too. The overall mortality of ruptured aneurysms is almost 80 to 90%. And these are challenging patients because clamping, blood loss, hypothermia, coagulopathy, vasoconstriction, all of them contribute to the mortality. If you look at open abdominal aortic aneurysm repair, it has gotten better, there's no question. The mortality has gone down from 48% to 41%. But the question is, are you satisfied with this kind of improvement? The advantages of EVAR is, the biggest advantage is we do not clamp. There's no blood loss. There's not much hypothermia. And you can do it even under local anesthesia. So let's look at what data is out there. Look at these retrospective studies, and you'll realize 90 ruptured AAA patients with EVAR done in 7 years, 30-day mortality, 27%. 102 rupture patients done in 10 years, 30-day mortality, 13%. What was the mortality with open repair? Almost 37%. If you look at all of the EVAR for ruptures versus open surgery for ruptures, you will see that the pooled 30-day mortality is around 20% for EVAR patients versus 36% for open surgery. So there in itself, this seems to be a better option compared to open abdominal aortic aneurysm rupture repair. So the benefits are there's a decrease in 30-day mortality, there's decreased long-term aneurysm-related death, and there's a marked decrease in ICU stay and total hospital stay. There has been only one randomized control study and 33 non-randomized case series, 24 which were retrospective and 9 prospective studies. If you look at this systematic review of all the data comparing open versus endo, and you'll see that the mortality rate for EVAR is 17% and for open is 34%. This slide remains in my head because it's such a beautiful color combination. This is Dr. Frank Wheat's slide. And he showed early, too, that the 30-day mortality for patients treated with endovascular repair for ruptured aneurysms is 19% compared to 37% in open. So obviously, the scales have tilted. The balance is clearly towards the endo repair. But then there are always people who will say, show me the data. Where is the level 1 evidence data? How can you get level 1 evidence data on a ruptured patient? It wouldn't be ethically correct. But there has been one paper of a randomized controlled trial that actually compared EVAR with open. And this was done by Dr. Hinchcliffe. And basically, this is the only one that compared it in a randomized trial, and it actually failed to demonstrate superiority of EVAR over open repair, with basically saying it's about equivalent. And that is the only one that can actually contradict to what I'm presenting and what the data out there is. So we've definitely come a long ways from open to endo. Endo is clearly better in terms of morbidity mortality. But there's also limitations of this technology in these ruptured patients. And one of it is not all of them may be candidates for endo, the availability, and also the complications if you need to re-intervene. So there are obstacles to programs to do endovascular repair, and that is why you need to have a very structured algorithm or a structured program. This question is very clear. Is EVAR superior to open repair for ruptured AAAs? A very clear-cut yes. But the question is, can we get even better? Can we improve the outcomes of these ruptured AAA by incorporating an EVAR protocol into every institution? And this was published by Dr. Manish Mehta from Albany. The benefit of a structured algorithm, and clearly you can get this slide from anywhere in any textbook too. So there was a study done where they evaluated centers who had a structured protocol for ruptured aneurysms versus those that didn't. And if you realize that this, you'll see that the mortality and odds ratio, you'll see that those centers that had a pre-protocol did markedly better in terms of overall mortality and morbidity. So if you have a very structured protocol in terms of availability, in terms of anesthesia, in terms of CAT scans, and in terms of hybrid ORs, then the mortality from endo will drop even further than what we have right now. So the mortality rate for open repair of ruptures is still very, very high. Emergency EVAR for treatment of ruptures should be the first approach, and then introducing a structured protocol is probably going to make it even better. Dr. Rodriguez and I and a whole bunch of fellows, along with Dr. Dietrich, did publish a ruptured date. And you'll see you got to have a team, you got to be organized, and you got to have the technology and the skills. This is the patient who came with a rupture. As you can see, we treated him endovascularly nicely. And the role of the occlusive balloon is another important factor, and how to use it is very, very important too. So if you look at our data, you will see the philosophy behind how to do this. When do you consider EVAR versus open? You don't have to take the whole day to decide all this as the patient is being wheeled into the operating room, but you need to be already aware of how to do this. The decision-making versus local versus general, how do you deal with the retroperitoneal hematoma, what kind of endograft do you want to use, so all of these. So we did about 147 cases, presented 84 were done open repair, 63 were done with EVAR. I won't go into all of the details, but the type of endograft at that time, we used endologics a lot because one of the important factors when you treat ruptures is gate cannulation. And that can take a long time, especially with the integrity of the aneurysm that is compromised. So endologics has no gate cannulation and is very quick and easy to use. So the bottom line of all this was that our overall mortality was 32. But if you look at open versus endo, you'll see that the endovascular repair group, the overall mortality was about 19%. So the technique is very simple. Actually, it's not very challenging, very detailed. You just have to be aware of what to do and how to proceed with the algorithm, occlusive balloon, and then when to induce the patient for anesthesia, especially when he starts moving around, and at what phase of the operation do you want to induce anesthesia. The aortic occlusive balloon was used in 35% of our cases and twice as often in EVAR. And using the occlusive balloon has actually statistically significantly dropped our mortality rate, and therefore you can decide on the use of the occlusive balloon by looking at the retroperitoneal hematoma, how hypotensive or how compromised the patient is. The second factor that you have to deal with is the abdominal compartment syndrome, and that also you should be able to treat this either from a retroperitoneal approach, or you may have to open the entire abdomen and then put a wound vac on it to combat the retroperitoneal hematoma. So EVAR has definitely decreased our mortality from 40% to 18% in a series, and this keeps in line with all of the other data available there, where the mortality for ruptured aneurysms treated with endo has gone down to almost 18 to 20%. So I'll go quickly here, since I didn't get my time in the debate, to show you what is required for the management of the ruptured AAA. On-call endovascular team, high-quality OR, fluoro unit, large stock of endografts of various sizes, aorta uniiliac devices, occlusive balloons, and sheets. You would need all of this too. Adjuncts, hypotensive, keep the patients a little hypotensive till you get access, till you get the occlusive balloon, and then if you want to convert to general, that's fine. We do a lot of these percutaneous. Intravascular ultrasound is an excellent modality, especially if you don't have a very good CAT scan on these patients. Sometimes they come straight without any CAT scan. And then the choice of endograft. Aorta uniiliac is probably the best way to seal it, and then do a fem-fem. But again, if you can do a bifurcated graft, it's probably the best way to do it. General anesthesia versus local, that's a judgment call depending on how the patient behaves. And if you really want to see how it quickly goes, is the first thing you do is you get access, put an occlusive balloon. You can shoot an angiogram if you don't have one right below that occlusive balloon, and then decide whether the patient is a candidate for open or endo. If he's not a candidate for endo, you can leave the occlusive balloon in and prepare to open the patient. The next thing you do is deploy the main body very quickly, put the occlusive balloon back into the main body, and you have enough time to cannulate the gate. In fact, this facilitates gate cannulation because that wire will come into the gate even if you go up and over, and then you're done. So relatively simple, but you've got to have a very good team in these high-risk patients to get really good results. And you can actually deploy some of the stent grafts even with an occlusive balloon sitting up there. Even those with suprarenal extensions and cuffs, you can do that even with the balloon sitting up there. In terms of choice of endograft, aorta uniiliac is probably the best, quickest, and the best way to treat it. Modular devices, you've got to be very careful as to where the gate opens. Endologics is a very slick device for these high-risk patients with no gate cannulation. Get access, put the cuff, and you're done very, very quickly. So this is the summary, basically, that says that EVAR is definitely the first choice for ruptured abdominal aortic aneurysms. Thank you.
Thank you, Venki. You must be tired from talking, but you did an excellent job, and we appreciate that. We have about 15 minutes left, and so we would like to open this to discussion. I'm sure there are some questions from the participants here, so please feel free to come to the microphone and ask questions related to any of the presentations so far. While we are waiting for this, I think that debate was excellent. Unfortunately, Venky's presentation was not available. Venky, but you did a nice soft shoe presentation there. I congratulate you on that. But Mark also has to be congratulated on very detailed and elaborate information on the literature, what's available. My personal view is that the information is still not in, which technique is better. It's unfortunate that the technology, the industry is lagging behind, because there is no doubt that we need dedicated equipment that will be approved for that IFU. And the current devices that are commercially available, they are in limited release type of mode, so not everybody has them. There's also a time-consuming factor in ordering, so on. And there are issues, they're not perfect, with kinking of the branches and so on, that Ventana has clearly shown that, and also the Gore device. So I say that's why the audience so favorably rated chimney approach. That's my also personal opinion, but there's no doubt that the technology will catch up, and eventually chimneys, the way we do them now, will disappear, and the industry will respond to our needs. That's my personal view, but maybe some of you can also comment on that as well.
I got a question for Venky.
Yeah,
Yeah,
go
I
ahead.
appreciated your talk, Venky, on Type B dissections. I think it's very interesting, and I think it's kind of such a new area that I think a lot of people are going to be trying to treat these and not really having a clear plan. So I liked your idea, or what you were mentioning about the false lumen thrombosis and how there's variation. Does it matter, is my question. Do you have to get, I mean, is the future rupture risk better the more false lumen thrombosed, or should we worry about it? Should we be doing anything different, or should we just accept what we have? And
Well, a couple of things. If you can get complete thrombosis of the false lumen, that's probably the ideal way to treat acute dissections. That decreases sac enlargement, causes better remodeling, and better distal perfusion. The top proximal one-third, false lumen filling there is basically a failure. So if you have antegrade flow after a thoracic stent graft for an acute dissection with compromise, then you need to seal that. Whether you have to go into a carotid subclavian and go to the carotid, you have to seal the entry tear. Then what we do nowadays is we then do an IVIS to see if there's any major fenestration in the mid-segment of the aorta. And we try to then cover that mid-segment at least till the celiac, when the septum is intact. So now your retrograde flow is only in the distal one-third of the aneurysm sac, and that's a much better chance to seal and decrease the incidence of aneurysmal dilatation. So you can not always eliminate retrograde flow. In fact, 70-80% of retrograde flow will always remain. But as long as it doesn't reach the proximal one-third, or maybe even up to the mid one-third, you'll get better results.
The question is for Dr. Krejcir. You know, now that we have endo-anchor available, I enjoyed the talk very much, and we have done a few of these cases in the past. Can we extend the limitations of doing EVAR in the sense that utilizing endo-anchor, can we treat a 3 millimeter, 4 millimeter neck without proximal, without a top bare metal stent? Just use the endo-anchor to anchor the device and then complete the procedure? What do you think?
We do that quite routinely, and actually with very challenging, very short necks, you can get rid of endo leak and risk of migration. So you can avoid the use of chimneys in that kind of a scenario. But it doesn't always work. Like you can take a scenario, you have a very short neck, but you have circumferential thrombus formation in that area. The anchors will not work, particularly if the thickness of the thrombus is 2 millimeters or larger, or if you have a circumferential calcification in that area, then you'll have to extend it upward.
So in a scenario like if you have an aneurysm which is hugely enlarged, say 10 centimeter aneurysm, and the aneurysm is pushed to the right side, Now, if you put the endo anchor, is it possible that the forces in the future can actually push the device down, or anchors have a significant high fixity rate?
I don't know that. We don't have enough information on a long-term basis in this type of scenarios. Venki, can you speculate on this?
Using anchors for de novo aneurysms, not migrated or type 1 endoleak with a stent graft, is to get into healthy aorta. So if you can land 1, 2, 3, 4 staples or anchors in a healthy portion of the aorta, whether it be 5 millimeters, 4 millimeters, I think you'll get a very good result. Long-term data, whether that is going to migrate or not, is still not available because we've enrolled, 400 patients out of 1,000 in this registry. So that is still to be seen. But we've done a lot of these. They work very well. It's very easy to use. You can retract them if you're not happy, and they deploy very nicely without any other major complications. So for migrated endografts, I think this is an ideal technology.
So you have to keep in mind, as far as IFU for endoanchor is concerned, it's not approved for anchoring two components of the stent graft without the aortic wall. You have to have apposition of the aortic wall, because we don't know what happened with those endoanchors. They can get dislodged, separated, whatever.
Can I ask one more question to Dr. Maya? We ruptured AAA, and nowadays the EVAR is considered more or less standard of care because we are very good at it now. But some of the European data which came out after the trial indicate the open surgery is better than EVAR. What do you think about that?
Which trial?
I don't remember the exact name of the trial.
So there was one randomized trial.
One randomized trial, yes.
Hinchcliffe. It didn't say better. If you looked at the mortality, I think the slide didn't show, it said it was equivalent. 53% was the mortality with open versus endo. And that was a while ago, way out before all of these stent grafts technology changed. So I think that one paper should be buried.
Agreed.
Vicky, in terms of the type B or 3 dissection in the asymptomatic patient, you talked about Chris Nienaber's data. Recently, in a couple of meetings I've been with Chris, Chris now has a slide that says, for that particular scenario, the gold standard is the endograft.
Yeah, I think there's a changing shift, and we're seeing it in our practice too. We are bound by so-called compliance and indications and IFUs and everything. But like I said, we had a subgroup of patients who had soft signs, about 20 to 25 people, who basically blood pressure was not controlled and the pain was pretty significant. No malperfusion, no enlarging aneurysm. And we treated them with endografts, and that was the best cohort of patients ever treated. So I think the data will change, and we'll probably be treating these patients. In fact, I have a beautiful slide of a patient who had an ascending dissection treated with a tube graft. And then he started developing aneurysmal disease. Started with the abdominal aneurysm, common iliac aneurysm, treated with endograft. Patient had an EF of 5 to 10%. Then put an endograft in the mid-thoracic portion. So the pathology is pretty bad in these patients, and a lot of them go on to develop aneurysmal disease, which becomes very, very complicated to treat later on. So if, as Dr. Dietrich said, the data of the INSTEAD trial, and Chris says that we should treat these patients because now the technology is very good. There was a crossover of medical arm patients into the surgical arm, and the complications were basically related to access and groin issues and infections, not really deaths from endografting of these asymptomatic or uncomplicated patients. So with the technology getting better, the devices getting smaller, tapered grafts coming into the market, I think I agree totally with Dr. Dietrich that this may become the gold standard for uncomplicated thoracic dissections.
I have a question. The Nelex, where do you think Nelex is going for the no neck? In the trial, right?
Well, we are all, I guess, in the trial. And as you know, the trial is very restrictive as far as indications are concerned, which is almost no different than any other trial. So we here in the United States, we don't know because we have not done procedures in very challenging infrarenal neck anatomy with this device. But when we look at the Europeans, and they are now gaining more and more experience, and this is becoming a very popular technology, they're very enthusiastic, and they're doing a variety of things that we will probably do in future, where they're actually doing chimneys to the renals and molding the Nelix material or to the irregularities of the aorta and doing what we do now with chimneys and extending the stangorats upwards. So it's very promising. But Mark, you know more about Nelix than any of us because you have started this very early. What I wanted to ask you, actually both Marks, we have two world-leading endovascular interventional radiologists, type 2 endoleaks, okay, which Nelix is important for treating, but it's a problem that really annoys a lot of us over a long period of time when it causes enlargement of the aneurysm, and you have to treat it. Now, I know, Mark Mewison, you have advocated treatment trans-aortic limb or stent graft, cannulation, and direct approach. And Mark Woolley, you have done translumbar and coils and onyx glue and so on. Can both of you, from your point of view, comment how you prefer to treat those complex type 2 endoleaks?
Mark treats them totally different than I do. You have to be very careful that you don't become good at taking care of type 2 endoleaks, because if you do, you're going to start to get referrals. They're very time consuming.
You can at least bill for the consult. You may not bill for the procedure because most type 2s you won't treat, right?
It's very time consuming. Now, surprisingly, the IMA is probably the most significant of the endoleaks and probably is the easiest to do. It's the small little lumbar vessels that take forever to catheterize, and for the radiation exposure is overwhelming. So we do it, and we're using onyx and we're using coils. We've used everything the best you can. You take one, it's almost like they're like almost AVMs. You take one out and they recruit from another site. So it's just continual. So you do the best you can, and then there's some that you taking care of every lumbar, you're taking care of the IMA, you still have a leak, and the aneurysm grows. We have one patient that went from 6 cm to 10, and he's still there. So now we're going to bring him back, and we're going to do another translumbar and direct the catheter, hopefully to the leak site, and inject onyx. But most you can control, and I'm glad that the type 2s most often don't amount to anything, which is very pleasing. But I think that I'm sure Mark agrees. Mark's using an interesting technique he'll tell you about, but what we would use a pretty standard technique, time-consuming, just coiling or onyx.
What we've been doing in it is getting into the sac. I think probably the best way to do, because I've got a case on Monday where they've gone through the SMA, gone through the internal iliacs, and tried to coil this. And this huge IMA, which is aneurysm sac, has gone markedly increased. So what we've noticed now is to go CT guided, go right into the area there, and it's pretty accurate. Do a CT-guided puncture right into the area of the endoleak, put your catheter, then go to the endosuite, and then through that area of that catheter, you can actually cannulate the IMA, cannulate the lumbars, and you can really get a very good result, whether you use glue or coils. The other thing that I have not really mastered, and I think my partner Julio, is unbelievable. He can invariably and almost 99.99% get a wire behind the endograft from the groin. On 99, I mean, every time he does it. He takes an angle catheter, sits at the limb of the iliac limb, goes through it, pushes through it, gets into the sac, coils, thrombin, gel foam, coils, glue, whatever it is, then puts a balloon in the limb for about 5-10 minutes to seal in case it tears it or anything. And he's got great results, great results. I mean, it's a skill that I have not yet mastered.
Mark, Mewison, can you tell about your technique?
Well, the reason your partner can get behind is because you put the graft in and you undersize the iliac limb. Undersize the iliac limb. I look at a type 2 endoleak as an AVM. And whatever technique you use, you have to be able to get into the nidus of that AVM to cauterize it. You know, we've treated AVMs in the legs, we've treated AVMs anywhere, and we know that if you just go after one vessel, obliterate it, 3 months later, you know, it's going to recruit and come back. And so, that being said, you have to be able to predictably and very precisely get into that nidus. Now, all the techniques that you've described, we've done, and unfortunately, they're not always, you can't always get there. So this technique that we've been using is we know exactly where the endoleak is on a CAT scan, right? So you get access from the femoral artery, either the left or the right, depending on where the leak is with respect to the limbs. And then you use a 6 French curved catheter to get right towards the leak, and you know exactly where it is. You know, you can rotate it, and then you use a little laser probe to actually puncture it. And you can puncture Gore, you can puncture Cook, you can puncture them all. Then you have an 014 guide wire. Then you put one of those little echelon catheter, which is 3 French. You know, it's 1 millimeter. And then through that, you can do your entire procedure. And you never have to get into the intercostals, I mean, the lumbars or the IMA. You just get, and you keep filling it with onyx. And you'll see onyx, as you know, it's like lava kind of crawling down a volcano. You know, it sort of takes the path of least resistance. It actually obliterates. It can even get into the lumbars and the proximal IMA if you have to. So the techniques of translumbar, it's of course a very good technique, but if it's a right-sided leak, or if it's a low leak, you have the pelvic bones in the way, or you have the IVC in the way. It's not always, even if you have a wizard with a CT Shiba needle guided and so forth, it's not always predictable to get into there. This technique gets there all the time.
Is it contraindicated in PTFE?
No. Think about it. We've been putting 6 French sheath, to bypass grafts to the groin.
As that, endo anchors are contraindicated for the endologics, right? So the PTFE can tear very easily compared to Dacron. And so puncturing it, lasering a PTFE may still create a new endoleak, like a type 4, a hole in the graft. So I don't know your experience between PTFE material and Dacron.
But that's only for endologics because it's a specific design of a... Yeah, Gore is okay. Very good. Thank you very much. So we'll take a break and we'll reconvene at 11:05. Thank you for your participation.